Hi, my name is Atif Darwish, professor and consultant of obstetrics and gynecology. If you look to the topic of thin endometrium in publications, you will find that most of the publications focus on the IVF XE patients. And we can ask a question, what about other non-IVF patients or other infertility patients or patients submitted to IUI or controlled ovarian harvest stimulation? You will not find many publications focusing or highlighting their problem. So I designed this lecture to highlight the difference between the IVF and non-IVF thin endometrium. You know that there is no consensus on what constitutes a thin endometrium, and some publications found it is equal or less than 7 or equal or less than 8 millimeter on the day of ovulation triggering. And the discrepancy in the definition of thin endometrium comes from different heterogeneous factors like intra and inter-observer variations in measurements, effect of uterine contractions of on endometrial thickness, the use of different simulation protocols, various body mass indices, different methods of reporting estrogen and progesterone concentration on the day of triggering, endometrial thickness measurements made on different days, like day of triggering, day of oocyte retrieval or embryo transfer, categorization of endometrial thickness with different cut-off values, inclusion of women in a wide age range undergoing fresh or frozen natural or stimulated cycles, number of embryos, and quality of embryos transferred. So there is a great discrepancy between publications and heterogeneity. That's why there is no consensus universally agreed. And in this figure, you can see that the endometrial thickness varies if you studies use day of HCG administration or day of oocyte retrieval, day of fresh embryo transfer, day of embryo transfer for non-fresh or frozen cycles. We have to know that pregnancies with thin endometrium, as thin as 4 millimeters, have been reported. So the topic of thin endometrium is controversial regarding its impact on pregnancy rate. Now we have to talk about how to measure endometrial thickness it should be by transvaginal sonography, and the probe should be perpendicular on the endometrial cavity in the mid-sagittal plane, and patients should have an empty bladder. You calculate the maximal echogenic distance between the junction of the endometrium and myometrium. Nearest point to the fundus, exclude two, which are surrounding inner myometrial translucency and any endometrial fluid. And sometimes, or mostly, it is calculated on the day of HCG, but you can measure it in different days as previously mentioned. Why all these sophistications for calculation or for measurement of the endometrial thickness? Because endometrial thickness is considered as one of the important predictors of endometrial receptivity, but it is not the sole marker. Why? Because there are some confounding factors like age of patient, estrogen concentration, oocyte number and quality of transferred embryos, and the euploid status of the embryo. So it is just one, but one of the most important predictors of the endometrial receptivity. And of course, there are some reliability factors already previously mentioned regarding the accuracy of the studies and the heterogeneity of publications. More studies and more discussion of this topic is found in this YouTube channel in the lecture entitled Endometrial Receptivity, a Simplified Approach. Take care that it is not just measuring the thickness. You have to comment on the appearance of the endometrium. There are 4 types of endometrium according to the aspect of myometrial, endometrial, and endometrial interfaces and texture or thickness of functional layer. There is type 0, which is proliferative, thin, pencil-like endometrium, type 1, trilaminar structure, but there is hypoechogenic area around this trilaminar area, but type 2, there is hyperechogenic thick base, and type 3, the thick homogeneous echogenic. Type 3 and type 2 and 3 are post-ovulatory in 100% of cases. So if you see the trilaminar plate as echogenic, it is considered post-ovulatory. But if it is translucent around its area, it's mid-follicular and until 2 days of ovulation, as previously published. If you look to the infertility evaluation, you will find the prevalence of thin endometrium is low, is not too much in infertility practice. And the incidence is much more higher in the non-IVF patients, reaching up to 40% patients subjected to clomiphene letrozole, gonadotropin, or combination stimulation protocols, while in IVF patients, it has been reported to be 1 to 2.5% of most of studies, but there are some criticism regarding these studies because they exclude the cancelled cycle. So if we consider thin endometrium in the cancelled cycle due to other cause, the incidence may rise. But if you look to infertility services, for example, this publication of National Survey of Family Growth, you will find that ovulation drugs are given to 4% of cases, IOI in 1.7%, IVF or XZ in 0.5% of cases. Another study of the same National Survey of Family Growth found that assisted reproductive techniques presents only 3% of infertility management, ovulation induction in 27% of cases, IOI in 7%. So it seems illogical that you focus on IOI, which presents low incidence of the infertility services. We have to focus on the patients subjected to ovulation hyperstimulation. And the etiology of thin endometrium may be related to age. The higher the age of the patient, the thinner the endometrium. Low estrogen, of course. You have to think estrogen as a cause and treatment. Luteal phase defect, some medications, iatrogenic by operations like curettage or hysteroscopy or any evacuation or any intrauterine surgery, genetic cause, unexplained cause, vascular incompetence, or infections. So you will tell your patients that your endometrium is thin. Okay, what's the question of your patient? She will say, what's the value of having thin endometrium or normal endometrium? You have to inform her that thin endometrium is associated with decreased implantation and pregnancy rates, and this carries poor IVF outcome or poor infertility management outcome. Why? Because vascular endothelial growth factors were underexpressed in thin endometrium less than 8 millimeter, with poor vascularization of the endometrium and impaired placentation, as previously found in many studies. And in this figure, you come from another study, you can see that the endometrial thickness between the more than 8 up to 13 is associated with higher chemical and clinical pregnancy rate. So the patient, you have to tell her that there is decreased implantation pregnancy rate, and there is possibility of recurrent implantation failure of non-employed embryos in IVF XC, and increased obstetric and neonatal complications like hypertensive disease of pregnancy, preterm labor, placenta previa, cesarean section, pregnancy loss, IUGR, and small for gestational age, and lower birth weight. These are the possible risks of having thin endometrium. So this is your answer to the patient. And you have to tell her that the impact of thin endometrium on controlled ovarian stimulation cycles is not highly addressed in publications, as I already mentioned, and there is less agreement regarding its impact on the IOI cycles or controlled ovarian stimulation. This part, however, in IVF XZ, the impact on of the thin endometrium is well accepted. Okay, the patient will ask you what to do if you find a thin endometrium by ultrasound in the day of HCG administration. So what to do if thin endometrium is, if the endometrium is properly assessed and thin endometrium is documented by TVS? So the management depends on what's the purpose of monitoring. Is it non-IVF or IVF patient? The second item is other confounding factors, which are employed status of the embryo and age of the patient, other associated problems like intrauterine surgery and otherwise, and history of this patient has repeated thin endometrium or not. If we stratify our patients as non-IVF thin endometrium, we have to start by counseling. You have to sit down as a couple and tell them the previously mentioned risks, and there are list agreements regarding the impact of this thin endometrium on controlled ovarian stimulation with IUI cycles. And you have to tell her that clomiphene citrate is associated with lower endometrial thickness. IUI, there is no difference in the endometrial thickness between patients who conceived and those who did not conceive using clomiphene citrate, letrozole, and gonadotropin in some studies. And you can make no cycle cancellation despite thin endometrium. And you have to reassure your patients that pregnancy rate may not be affected, but the studies are not so strong regarding the impact of thin endometrium in non-IVF cases. After counseling of your patients, you can do a compilation of the cycle of controlled ovarian stimulation or IOI. Now the patient, if she got pregnant, okay, she is lucky. If she did not get pregnant, she will come to you again and the subsequent cycle. The subsequent cycle, you have to make some practical steps. The first is to switch from clomiphene citrate to letrozole or HMG because clomiphene citrate is associated with thin endometrium. You have to think estrogen as a causal therapy. You have to add estrogen supplementation or adjuvant therapy, as you will see now. You can offer your patient hysteroscopy to rule out intrauterine lesion or intrauterine adhesions. You have to exclude acute or chronic endometritis and additional therapist discussion with the patient. Why we have to shift from clomiphene citrate to letrozole? Both clomiphene citrate and letrozole send messages to the hypothalamus and pituitary that there is less estrogen in the circulation, and they have to work to stimulate secretion of estrogen. So what's the difference? Difference that clomiphene citrate binds to estrogen receptors and depletes receptor concentration. So the receptors in the hypothalamus and pituitary will be occupied by clomiphene citrate temporarily. And this will lead to disrupted or interrupted estrogen negative feedback mechanism, which means that the hypothalamus and pituitary have false impression about the circulation. The message that there is no estrogen, okay, we will give you FSH stimulation, and this FSH should come to the follicles to increase the follicular size. But the FSH is continuous, so it will increase the size of small follicles who have less FSH receptors and large follicles at the same time. And that's why clomiphene citrate is associated with multiple follicular development and, of course, multiple pregnancy rates if big follicles are exposed to FSH. Okay, FSH is continuously stimulating this follicle. Where is the negative feedback? No negative feedback because the receptors are occupied. So the continuous stimulation of FSH leads to multiple follicular development. By this way, the excessive production of the follicles and binding to receptors will lead to decreased endometrial thickness, no estrogen, decreased globular density, decreased uterine flow in luteal phase, decreased quality and quantity of cervical mucus, and hot flashes, of course. On the other hand, letrozole gives information to the hypothalamus pituitary center that there is no estrogen. Why? Because it has dual function. by occluding the aromatase enzyme effect that transform androstenedione to estrone, estrogen 1, and testosterone to estradiol, estrogen 2. So this dual action of the letrozole as aromatase inhibitor will lead to impression to the hypothalamus and pituitary that there is no estrogen. But the effect of this letrozole is not affecting the estrogen negative feedback mechanism. This is preserved. Here is interrupted. So the hypothalamus, okay, will start to send to orders pituitary to send FSH stimulation because GnRH released from the hypothalamus. Here, the receptors are occupied by the clomiphene, and there is negative feedback stimulation. So excessive FSH leads to excessive estrogen that leads to negative decreased FSH and so on. So there is intact hypothalamic pituitary ovarian axis and more FSH receptors in the big follicles. So the bigger follicle or the dominant follicle will grow, while the small follicles will fade or will be exposed to atresia because they have less FSH receptors due to falling FSH in this negative feedback mechanism. And so this is the difference between giving clomiphene citrate or tamoxifen and letrozole. Both decrease estrogen and both send information to the hypothalamus and pituitary that there is no estrogen or temporary no estrogen, but the letrozole is more physiologic as it preserves the feedback mechanism. The second point is to think estrogen as a cause and therapy, ensuring sufficient exposure to estradiol by augmenting oral therapy, patches or vaginal cream or gel, and this is the mainstay of management. You can add oral ethinyl estradiol from day 5 to 9. Usually we use from day 5 to 9. This publication for 7 to 10 is okay. 200 to 500 microgram for 5 days. Vaginal estrogen, 25 milligram daily from day 4 to day 15. Increase dose of estrogen. There is no significant difference between oral, vaginal, or patches. If you use estradiol valerate, you can increase the dose up to 16 milligram daily from day 3 to 9 in some publications. So you can switch from one type to another, increase the dose, and you have to know that vaginal approach is the best approach. If you add estradiol valerate 2 milligram every 12 hours from day 6 until ovulation, this will increase vascular endothelial growth factor, and this leads to uterine vasodilatation and endometrial proliferation. And it has been shown to be more effective than giving sildenafil, which is given 20 milligram every 12 hours for 5 days, starting from the last day of menses until ovulation, which works by increased smooth muscle relaxation, vasodilatation, arterial blood flow increase. But it has been found in this study to be more, the estradiol is more effective than sildenafil. Don't forget to offer your patient hysteroscopy to rule out intrauterine lesions, intrauterine adhesions. And if you find adhesions, you should offer your patient early post-operative second look to treat any reforming adhesions. And many details about this procedure are found in this lecture in the same channel. You have to exclude endometritis, whether acute endometritis, by taking biopsy to find neutrophil infiltration, chronic endometritis plasmacytes, and this can be done hysteroscopically guided. And don't forget the role of hysteroscopic staining, which is chrome hysteroscopy. And you can find a video in this channel also on the role of chrome hysteroscopy, and this publication by our team this year on the role of chrome hysteroscopy in infertility. So hysteroscopy is important, and you can diagnose endometritis, chronic endometritis, by seeing multiple micropolypi and strawberry aspects in the endometrium. What about additional therapies? Many publications highlighting additional therapies, and should take these therapies on an individual approaches. You have to tell your patients that counseling or the experimental nature of these treatments should be put in mind, and potential adverse effects should be put in mind. So she has to select, and you can select these additional therapies or one of them according to your patient situation. If you give her all lines of treatment and still endometrium is thin, the conventional therapy is giving her growth hormone, granulocyte colony stimulation, sildenafil, as I already mentioned, vasodilator substances like aspirin, nitroglycerin, pentoxifillin, L-arginine, vitamin E, or acupuncture. And some cell-based therapy like platelet-rich plasma, PRP, stem cell therapy, or tissue engineering. One slide on each of these lines here: granulocyte colony stimulation, meta-analysis on 20 randomized controlled trials in IVF patients or patients with recurrent implantation failure found that it can induce proliferation of endometrial epithelium and stromal cells by increasing staining levels of proliferative cell nuclear antigen and stimulate direct differentiation of stem cells. And actually, granulocyte colony stimulation factor is a glycoprotein synthesized by bone marrow cells, stromal cells, and including endometrial cells. What about PRPs? A famous procedure can be done even in the cycle of frozen embryo transfer before starting estradiol. The cycle prior to estradiol, you can start it or any time by hysteroscopically guided. You can inject subendothelial. Some studies injected in the endometrial cavity, but it's better to inject subendothelial, which is actually autologous blood plasma enriched with 4 to 5-fold higher level of platelets, so it has higher growth factors and cytokines. Some studies found it's effective in induction of growth of the endometrium. The same applies for stem cells, which are investigatory. Further research is required because they increase cytokines, growth factor, natural killer cell activity, and others. Tissue bioengineering to put these tissues inside the endometrial cavity, and you can treat endometrial after endometrial adhesolysis, and otherwise, again, it is an investigatory step. So this is non-IVF thin endometrium. What about IVF thin endometrium? Again, you have to counsel your patient about the risks of thin endometrium, and the impact is well accepted in IVF patients. And although some case reports on successful pregnancy in IVF exist despite very low endometrial thickness, as low as 4 millimeters, the chance of pregnancy is low in these cases. So the patient has to choose. If the choice is to proceed to embryo transfer with thin endometrium, so this is the fresh cycle, ovulation stimulation. You can proceed, and if successful, she's lucky. If failed, you can start to prepare the endometrium as previously mentioned in non-IVF. But if the patient chooses freeze-all to attempt to achieve higher endometrial thickness, so you can discuss with her adjuvants like estrogen, like alternative endometrial preparation protocols. So in freeze-all, we have two main protocols: medicated frozen embryo transfer and natural cycle frozen embryo transfer. If it is medicated, which is HRT, giving estrogen, progesterone in a sequential fashion to mimic the physiologic, hormonal, and uterine environment observed in the implantation window. A natural cycle, just giving the patient monitoring until spontaneous LH surge, or modified natural cycle, which giving her HCG to have ovulation triggering. So natural cycle with or without luteal phase support or medicated. These are the protocols of frozen embryo transfer. If it is medicated, giving estrogen, already giving estrogen, you can increase the dose, you can increase duration until you get thin, good endometrium. You can change from one type to another, as already mentioned. If it is improved, you do embryo transfer, okay, give progesterone and start embryo transfer. If no improvement, you can postpone embryo transfer and continue estrogen until it becomes good. If no, you can offer your patient hysteroscopy, and you have to exclude endometritis and offer her additional therapies as previously mentioned. But what about natural cycle, frozen embryo transfer? This natural cycle in the stage of follicular growth, you can think estrogen by giving her dose of estrogen, oral, vaginal, or ethinyl estradiol or estradiol valerate or whatever. And after adding this estrogen to this follicular growth phase, either the endometrium improved, so can do embryo transfer. If no improved, you can postpone embryo transfer until you search for a cause of this in endometrium, hysteroscopy, exclude endometritis, or additional therapies. We have some cases of refractory or resilient thin endometrium, which is persistent, less than 8 millimeter endometrium in repeat cycle, despite all previous measures. And in such cases, you can consider embryo transfer despite not achieving adequate endometrium, because some patients may just never achieve a thick endometrial lining. And in some societies who allow, from a religious point of view, allow surrogate mother, you can offer the patient this procedure. And you have to proceed with embryo transfer and counsel that pregnancy rate and live birth rate are reduced, but acceptable in those cases. So in conclusion, I would say that in the era of precision medicine, individualization of management of thin endometrium is mandatory. Proper counseling is the key of success of management, and plan of management of non-IVF should be differentiated from IVF infertile patients. Thank you so much.